Welcome back to PCA Deep Dive, a service of the Pennsylvania Chiropractic Association. Each episode, we cut through complex research shaping healthcare policy and clinical practice and deliver the essential insights clearly, efficiently, and grounded in evidence, so you can understand what the data actually says without the noise. Today's deep dive focuses on a silent but rapidly accelerating global health crisis: chronic joint pain driven by osteoarthritis. This matters now because musculoskeletal conditions are among the fastest growing drivers of disability, healthcare cost, and loss of independence worldwide. Yet despite clear clinical guidelines, the care most patients receive remains misaligned with what the evidence supports. In this episode, we examine the scale of the problem, why current care pathways are failing, and what the research tells us about first-line conservative care, therapeutic exercise, and the critical role of movement-based, non-drug approaches in preserving function and quality of life as we age. This is not theory. This is about evidence, system failure, and how conservative care-first models can close the widening gap between guidelines and real-world practice. Let's dive in.
Our mission is to tear through the complex stack of research that you shared with us and deliver the essential insights so you can get well-informed fast. Today, we are focusing on something that's, well, it's a silent but rapidly growing global health crisis. We're talking about chronic joint pain, specifically the pain driven by osteoarthritis. And we're going to dive into the staggering scale of this, the surprising truth about what the best medicine actually is, and why our healthcare system seems to be completely failing to deliver it.
It really is a crisis, and it's one that's fundamentally shifting how we even define healthy aging. I mean, osteoarthritis, or OA, is already the world's most common joint disease. In 2020, it was affecting over 595 million people.
595 million. That number alone is almost impossible to imagine.
It is.
But the truly sobering part, and the reason we're calling it a crisis, is the forecast.
Exactly. When you look at the projections from the latest Global Burden of Disease study, the GBD, that number is on track to hit nearly 1 billion people by 2050.
1 billion.
In less than 3 decades. So you're looking at almost a billion people around the world dealing with a chronic disabling joint condition.
And that's just an unprecedented strain on healthcare systems. Not just the money, but resources, surgical suites, specialized practitioners, everything. So our focus today is to really drill down into the evidence for that first-line conservative care. We want to explore how specialized professionals like chiropractors can be strategically integrated to close this massive, dangerous gap between what the guidelines recommend and what patients are actually getting.
That gap is the whole problem. It's the core issue we have to tackle.
Okay, let's unpack that global burden first, because those 2050 projections, they're critical context. Can you break down the specific increase that we're looking at?
Sure. So overall, cases of OA across all joints are projected to go up by a minimum of about 48% and potentially as high as 95% by 2050.
Wow.
And the major load-bearing joints show huge growth. Knee OA is projected to increase by nearly 75%. That's 642 million cases. Hip OA is right behind it, projected to increase by almost 79%, getting up to 62.6 million cases.
Those numbers are just staggering for the joints that keep us moving. But the source material, it flagged an even bigger percentage jump in another category, right?
It did. And this is a really surprising nugget from the GBD data. The largest percentage increase is actually for other OA sites. So think, the shoulder, the ankle, the elbow.
Yeah.
That category is projected to increase by a shocking 95.1%. That's another 118 million cases right there. It tells you this is a systemic disease, not just a simple weight-bearing issue.
So a near doubling across the board. What's driving this? Is it just that we're all getting older?
Aging is a major factor, of course. People are living longer. But that doesn't explain the acceleration. The GBD study points to 2 primary modifiable factors: increasingly sedentary lifestyles and, critically, rising rates of obesity.
Okay, let's focus on obesity. If we just isolate high BMI, how much of the burden is that responsible for?
It's responsible for 20.4% of the global osteoarthritis burden.
20%.
Yeah.
And we need to pause here because it's not just the extra weight, the mechanical load on the knees, is it?
Not at all. That's a huge misconception. The sources really highlight that obesity degrades the joint through 2 completely distinct mechanisms.
Okay.
Yes, there's the mechanical load, but the second one is systemic. It's the high levels of inflammatory molecules, they're called adipokines, that are circulating in the blood and in the joint tissues of people with a high BMI.
So the fat tissue itself is actively poisoning the joint.
That's a powerful way to put it, and it's basically right. The body is producing these pro-inflammatory substances that actively degrade cartilage from the inside out. It makes OA as much a metabolic disease as a mechanical one.
And the human cost is measured in what's called YLDs, years lived with disability.
Yeah.
For anyone listening, what does it mean that OA was the 7th leading cause of YLDs for adults over 70?
YLDs measure the burden of living with an illness, not dying from it. So when OA ranks 7th, it means it's causing more chronic, long-term suffering and loss of function for older adults than many other major conditions we hear about.
It strips away their independence.
Completely.
Yeah.
And the burden is growing because the global population is getting older and heavier at the same time.
Okay, that makes the stakes crystal clear. A crisis that strips quality of life. But, and this is the good news the sources all point to, we have an incredibly effective, low-risk treatment. Which brings us to our next section. Movement. The literature is definitive. Therapeutic exercise is the best medicine. It's the primary line of treatment.
It is the gold standard, period. The troubling part is that this approach, which is so evidence-based, is described as being dramatically out of step with how medicine is actually practiced.
To understand why exercise is so powerful, we have to talk about how the joint actually works. Let's unpack the sponge analogy. Why is movement literally necessary for cartilage to survive?
So cartilage is unique. Unlike most tissues, it has no direct blood supply. It can't get nutrients and oxygen from capillaries.
Right.
It relies completely on diffusion, and that diffusion is driven by movement. When you load a joint walking, bending the cartilage gets compressed. That physical pressure squeezes old, waste-filled fluid out. It's just like wringing out a sponge.
And the second you take the weight off.
When you unload it, the cartilage expands again, and it sucks in fresh, nutrient-rich, lubricating joint fluid. If you sit still all day, that critical cycle just never happens. The cartilage essentially starves.
That completely busts the myth of wear and tear.
It does.
If you need movement for nutrients,
Yeah.
then a lack of movement has to be the real danger.
Absolutely. The idea that a joint is like a car tire that just wears down, it's so misleading, and it's harmful to patients. Joints are living tissue. They are in a constant process of wear and repair. Movement isn't the cause of the problem. It's the critical stimulus for the repair cycle.
But I think for the listener who has joint pain, their gut reaction is, if I move it, it hurts. I should rest it. How does the research say we overcome that fear?
That is the single biggest hurdle. And the research shows that even though patients fear it, therapeutic exercise is safe and it's effective. OA is a whole joint disease. It affects the bone, the ligaments, and very importantly, the muscles and nerves around the joint. Therapeutic exercise targets all of that.
So you're not just moving the joint, you're rebuilding the entire support system.
Exactly. If the muscles around a knee are weak, which is an early sign of OA, resistance training strengthens them. That improves joint stability and it reduces the damaging load on the cartilage itself.
And we have actual standardized programs that prove this works, like the GLAD program.
Yes, GLAD, it stands for Good Life with Osteoarthritis, Denmark. It's a fantastic example. And this isn't just go for a walk. These are structured, supervised neuromuscular programs.
Okay.
They focus very intensely on movement quality, on balance, and on strength training that's tailored to what the patient can do.
And what's the real-world impact for someone who does a program like that?
The trials show that people who participate see significant, sustained improvements in both pain and quality of life. And those improvements can last for up to 12 months. It shows that exercise, when it's delivered the right way, gives tangible, lasting results.
Which brings us to the great paradox of this whole deep dive. If movement is the best medicine, and we have proven programs like GLAD, why are we facing a 1 billion person crisis?
Right.
This gets us to the treatment gap, the failure of the current pathway.
The failure rate right now is systemic. I mean, it demands immediate attention. Research from developed countries, the US, UK, Norway, it reveals some really startling statistics on suboptimal care. Far too few patients are getting guided towards the exercise that the guidelines mandate.
Let's hit those two statistics that really jumped out from the sources. The first is about inappropriate treatments.
That would be the finding that more than 60% of patients with OA get treatments that the guidelines explicitly say not to use.
60%.
Yes. This usually means unnecessary pills, anti-inflammatories, or even more worrying, opioid prescriptions. So the patient is defaulted to a drug that just masks symptoms but does nothing to treat the actual condition.
That's a profound failure. And the second step? It points to a huge inefficiency, sending people towards surgery way too early.
This is the most shocking one, I think. Approximately 40% of patients are sent directly to a surgeon for a consultation before they've fully exhausted the conservative options, like therapeutic exercise.
40%. Almost half are bypassing the most effective, low-risk, and cost-effective treatment.
Exactly.
So for you listening, that kind of systemic failure, it directly translates to worse outcomes, both financially and clinically.
The consequences are severe. This pathway leads to much higher healthcare costs from things like unnecessary imaging and expensive consultations. Clinically, it increases the risk of chronic disabling pain. Patients get exposed to excessive opioids, sometimes unneeded surgeries, and it just accelerates their downward spiral. The evidence is clear. Conservative care has to come first.
So the system is fundamentally broken. If conservative, non-drug care is the answer, but the default is pills and early surgery, we need an intervention. We need specialized professionals right on the front lines. Let's talk about the strategic role of chiropractors, or doctors of chiropractic, in this solution.
This integration is so crucial. The sources note the chiropractic profession is deeply involved in global research, citing places like the Canadian Memorial Chiropractic College. This shows a real commitment to evidence-based musculoskeletal care.
And for you to utilize them effectively, you need to understand their training. DCs aren't just adjusting backs. They are licensed primary point-of-contact practitioners for these kinds of complaints.
That's right. Their training is comprehensive. It's a 3 to 4 year accredited doctoral program. We're talking a minimum of 400 to 200 hours of instruction.
Wow.
And critically, that includes at least 1,000 hours spent directly with patients in a supervised clinical setting. The whole profession is centered on non-drug, non-invasive therapies, and importantly, diagnostic autonomy.
Okay, let's talk about their core tool, spinal manipulative therapy, or SMT. It's mostly known for back pain. How effective is it?
For acute and chronic low back pain, the research shows that SMT on its own is as effective as other guideline-recommended treatments. And importantly, using it can meaningfully reduce a patient's reliance on pain medication. That's a huge public health win.
But the crucial insight, just like with OA, is that the best care isn't just one thing, it's multimodal.
Absolutely. The guidelines consistently say the best approach is always multimodal. You combine manual therapies like SMT with things like rehabilitative exercise or neuromuscular reeducation. It's the same comprehensive approach OA management needs.
And when you bring DCs in early for something like low back pain, the cost benefits are just staggering.
They're powerful. There was a retrospective analysis that found patients who started care with a chiropractor for acute low back pain had total medical costs that were $8,848 lower than those who started with a primary care clinician.
$8,000 lower.
And $12,267 lower than patients who started in the emergency department.
That saved money isn't just for the insurer. It shows that getting conservative care early prevents that expensive downstream spiral of imaging, specialist visits, unneeded drugs. It makes the whole system more solvent.
Precisely. They're acting as musculoskeletal gatekeepers, making sure the patient stays on that cost-effective, guideline-based pathway from the start.
Okay, last thing here. We need to clarify the distinction between doctors of chiropractic and physical therapists, because both do rehab and movement-based care.
It's a common point of confusion, and while both professions are highly trained and essential, DCs receive approximately twice as much academic and clinical training during their doctorate program. But the key functional difference, especially for you if you're seeking care, is scope of practice.
Tell us what diagnostic autonomy means in practice.
It means the doctor of chiropractic functions as a truly independent case manager. They can establish a diagnosis on their own. They can order or perform diagnostic studies, like an X-ray, without needing a referral from a physician to coordinate things.
So no bottleneck.
Exactly. For a patient with joint pain, it means you can walk into a DC's office, get a diagnosis, and start multimodal treatment that same day. It streamlines the whole process.
That ability to get the patient on the right path faster, combined with the proven cost savings, it makes the argument for integrating these providers overwhelming.
It really does. The evidence confirms this is how we start to reverse the treatment gap and tackle the looming OA crisis.
So if you're out there listening and trying to navigate a system that often fails to deliver that first-line care, the key takeaway is, well, it's pretty clear now.
The evidence strongly supports movement, therapeutic exercise, and a conservative multimodal approach as the first and best defense against joint pain, and integrating specialized, cost-effective providers like doctors of chiropractic into that primary care pathway. It offers a practical, high-value solution to ease the healthcare burden.
We have an impending global crisis approaching 1 billion people. And the solution isn't some new drug or a complicated surgery. It's movement combined with smart, collaborative, integrated care.
And here's one final provocative thought for you to explore. While the GBD study correctly identifies high BMI as a major risk factor responsible for over 20% of the burden, it also notes something else. It says other potentially modifiable risks, things like occupational hazards, certain injuries that could be prevented, they haven't been fully quantified yet. To truly stop that 1 billion case projection from happening, we have to move beyond just managing weight. We need to aggressively start quantifying and mitigating these often overlooked environmental and behavioral risks in our workplaces and in our daily lives.
That brings us to the end of this deep dive. Today's discussion reinforces a central message repeated throughout the literature. Conservative, movement-based care is not an alternative. It is the evidence-based foundation for managing musculoskeletal conditions like osteoarthritis. When delivered early and appropriately, it improves outcomes, reduces unnecessary interventions, and lowers long-term system costs. As healthcare systems face rising demand, workforce strain, and escalating costs, aligning care with what the evidence already supports is no longer optional. It is essential. If you found this episode valuable, please like, follow, and rate the podcast on your preferred platform. Doing so helps ensure this research-driven conversation reaches clinicians, policymakers, and decision-makers who shape care pathways. For PCA members, a companion infographic is available to download and share with staff, patients, legislators, and regulatory bodies. Science-backed resources like this are reshaping how conservative care-first approaches are understood, evaluated, and implemented across healthcare systems. Thank you for listening to PCA Deep Dive, a service of the Pennsylvania Chiropractic Association. Until next time, stay informed, stay connected, and we'll see you on the next Deep Dive.